I'm Ruth O'Regan. I'm a professor of medicine and division chief for hematology and medical oncology at the University of Wisconsin. So for adjuvant endocrine therapy, I think the big buckets are aromatase inhibitors or selective estrogen receptor modulators, of which tamoxifen is really the one that's used most widely. So I think for most of us, if we know that a patient is postmenopausal, we do tend to go to an aromatase inhibitor. The exception to that would be if you have somebody that really has, significant osteoporosis, where you might want to give a couple of years of tamoxifen and then transition to an aromatase inhibitor. I think we do that less and less because there is data showing that some of the bone modifying agents, such as zelendronic acid, actually can increase bone density or at least maintain bone density in patients on an aromatase inhibitor. And there's also some data in postmenopausal women suggesting that these type of agents actually can reduce the risk of breast cancer. So it's a long answer, but for a postmenopausal patient, typically an aromatase inhibitor with consideration of zelendronic acid if they have a low bone density. So for perimenopausal patients, so in other words, patients that aren't quite in menopause, they should be started on tamoxifen and then transition to an aromatase inhibitor when you're sure they're menopausal by measuring their estradiol levels. And that's typically what we would do in that scenario. For the younger women, but depending on how high risk their cancer is, you can either go with tamoxifen alone, which typically we would use for patients with lower risk cancers. But if they're younger with high risk cancers, then typically we'll use ovarian suppression with an NHRH agonist, along with either an aromatase inhibitor or tamoxifen. The data from the soft text study would suggest that actually doing ovarian suppression with an aromatase inhibitor is actually a little bit better than ovarian suppression with tamoxifen, or certainly better than tamoxifen alone. It's an important distinction to make, though, because obviously in younger women, when you basically essentially turn off all their ovarian function, that can be very hard for them to tolerate because they get, very significant menopausal symptoms. With hot flashes, insomnia, vaginal dryness, and I've actually seen patients with, quite significant depression as well. So we certainly do it. But I think in some cases you have to pull back and go back onto tamoxifen, which again is reasonable. But the soft text study pretty clearly would support the use of ovarian suppression with an aromatase inhibitor in a patient with a higher risk cancer.